Welcome once again, ladies and gentlemen. It is with immense pleasure to welcome all to this Times of Gynecology live webinar associated with Mumbai Obstetrics and Gynecological Society and the Maharashtra chapter of IAGE, the only platform where science witnesses maximum attendance. Today, menorrhagia is a menstrual bleeding that lasts more than 7 days. And it is not only bleeding, but it is also heavy. That's why we call it heavy menstrual bleeding, more than 80 ml. How do we control or how do we go about it? There are various causes of it. And today we will be touching upon these points. We do not want our women to undergo anemia. Let me not talk more. Let me go ahead and present to you the video. I request, please share the screen. Thank you.
मैं समय हूँ, मैं थक सा गया हूँ। यूं तो मैं चलता ही रहता हूँ, पर अब मैं भी कुछ थक सा गया हूँ। थक गया हूँ मैं सुनते सुनते कि मैं हूँ ही नहीं। लो, अब मैं हूँ ये कहने ज़रा रुक सा गया हूँ। मैं बेहद कीमती हूँ, पर मैं रुक गया हूँ तुम्हें तुम्हारी कीमत बताने को, कुछ अपनों की सुनाने को। मैं रुका हूँ तुम्हें अपनों से मिलाने को, हमें वक्त नहीं देते ये शिकायतें मिटाने को। रुक गया हूँ मैं तुम्हें खुद से मिलाने को, रुक गया हूँ मैं तुम्हें ये सृष्टि की धुन सुनाने को। कुछ पल रुक और देख इन कलियों को, बागानों को, इन नज़ारों को। तू तो भूल ही गया था पगले इन पंछियों के भी चहचहाने को। मैं समय हूँ, मैं थक सा गया हूँ, मैं थम सा गया हूँ तुझे बस यही कुछ समझाने को।
The objective of this video is to tell everyone that we need to introspect in these tough times and also work on adding our knowledge base. So I welcome all the esteemed doctors and I request you to share the screen. We have none other than our presenter, Dr. Krishna Kumar, who is President-elect of IAG and is the Chief Consultant at JK Women's Hospital. He is also the Secretary General of ISAR and does wonderful training for ICOG fellowship in endoscopic surgery at his hospital. Welcome, sir.
Thank you.
I also welcome Dr. Sarita Bhalerao, Vice President of MOGS. She is consultant at Bridge Candy, Reliance, Saifi, Bhatia, and also is attached to the Wadia Maternity Hospital. She was the Joint Secretary of FOXI in 2017 and the Quiz Committee Chairperson of FOXI 2009 to 11. Welcome, Dr. Sarita. Next
Thank
slide.
you, Niranjan.
We have Dr. Krishnendu Gupta, professor from Kolkata. He has got many degrees to name. He is also FRCOG London, FRCPI Dublin, and has done his MBBS from Mangalore and MD from Manipal. He was a chairperson of ICOG in 2016 and was the vice president of FOXI in 2011. Welcome, Dr. Krishnendu.
Thank you.
From South, we have Dr. Fessy Lewis. He is President-elect of FOXI 2021. Currently, he is an IVF consultant in the Department of Reproductive Medicine and Surgery at the well-renowned Amrita Institute of Medical Sciences, Cochin, Kerala. He is also the secretary of the Kerala chapter of ISAR and has got many hats he has donned. He was also the member of FIGO Reproductive Medicine Core Committee and currently the Vice President of KFOG. Welcome, Dr. Fessi. We have Dr. Amay Purandare. He is MD, DNB, FICOG and has done fellowship in Gynae Endoscopy, Germany. He is presently the member of Mumbai Obstetrics and Gynecological Society and served as the Joint Secretary of FOXI 2019 along with our President, Dr. Nandita Palchetkar. He is a consultant at Purandare Hospital, KJ Somaya Medical College, HN Reliance Hospital, Messina Hospital, and Naigaon Municipal Maternity Hospital. He was also the honorary secretary of AMOGS in 2014, 2015, and peer reviewer Journal of OBGYN of India. Welcome, Dr. Amay.
Thank you.
So with this brief introduction of our esteemed panelist and the presenter, I hand over the mic. Bleeding in women with endometriosis and fibroids. Over to you, Dr. Krishna Kumar.
Thank you, Dr. Niranjan Chavan, for the nice introduction. And I must at the outset congratulate MOGS and the Maharashtra chapter of IAG for including me in this webinar and for selecting this topic. I'm sure everybody is aware that we are now not allowed to operate. So patients even having menstrual bleeding due to this pathological condition, this was a good topic for you all to select as to how to control them medically or without major surgery, or if at all some surgery, some minor surgery. So just roughly to about your palm-Cohen classification, I wouldn't go into the detail. I'll restrict myself to that PALM, the PALM, for today's my presentation as to how such a minor surgery can avoid doing hysterectomy. You know, today FOXI and many of the organizations, we all are telling save the uterus. So I'm presenting some very, very rare cases. You know, this is a giant polyp, almost 5.5 centimeter to 6 centimeter inside the uterine cavity. It was a case of polyp. You can see the polyp right from the internal os. I'm sure you are appreciating the size is so huge. Right from the appearance itself, it is very clear that doesn't look malignant. You know, histopathologically, anatomy, you can correlate many a times that this doesn't look malignant, though there are some large vessels, the regularity is fine. And today with this simple resectoscope loop, one can avoid hysterectomy and the patient is home within 6 to 8 hours and mobile the very next day. So that is the beauty of hysteroscopy. So this today in current time and the current direction that general anesthesia and laparoscopic surgery is something which we all need to avoid. So this was all the specimens. So hysteroscopy is a great alternative where you want to really avoid surgery of major, apart from vaginal hysterectomy, nothing can be done today. Now this is a very beautiful case, adenomyoma, you know, presenting into the endometrial cavity, how it can be tackled by the hysteroscope. This is what I'm just going to demonstrate to you, a well-formed adenomyoma presenting with pain and heavy bleeding. How, see the rest, the cavity is quite okay. You could see the ostia. Now this is the projection. This is the bulge. This, you know, picked up by sonography that there is a big adenomyoma projecting into the thing like a submucous fibroid. You take your resectoscope, safe bipolar loop, you start resecting. Luckily, this was on the posterior wall, and posterior wall, any resection usually is a little more simpler than other walls of the uterus, lateral wall or anterior wall, which is maybe a little more difficult. Now, if you can appreciate that once you start cutting, you could see a big crater. So this appearance inside an hysteroscope looks very scary. Whether have you perforated, have you opened up the bowel? But definitely the distension is not lost. So this was picked up on ultrasound, a large adenomyoma. So what you needed was to just open up the cavity completely, cauterize the base, or resect that endometrium which is there. I'm sure you're appreciating this particular endometrium here. Inside that cavity, which is there very clearly seen, you can see the ectopic endometrial tissue, little more chocolatey material there. And what you need is just a little bit of patience. Open it up a little more so that you can enter into the cavity of the adenomyoma and cauterize it, or just resect that very superficially, taking care that you're not going too deep. Rather, you may perforate the uterus actually. But this is something which you have to train yourself as to how much you need to resect, because the loop can enter up to 4 millimeter, and this was very close to the serosa. So what you needed was a very superficial this, and this was the sonography picture just to show you how it was. So now this is a very, very interesting case which I came across. Hardly 29-year-old lady came to me actually for primary infertility with menorrhagia. You could see this HSG X-ray. I've never seen an X-ray film like this. Totally irregular. And from the look of it, definitely the surface is irregular and has something very much abnormal. And when we did a hysteroscope, this was global fibromatosis. I've never seen so many fibroids. You cannot just count. It's close to 40 or plus also. Small, multiple large fibroids, and this hemoglobin was just 5.5. She came in from Kanpur to me through a doctor from there, Kanpur, and she said, go and just get yourself treated here. The day she landed, we gave her 2 pints of blood and then posted her for hysteroscopy, and what we saw was something enormous fibroids. We thought of just resecting whatever we could in 20 minutes. About 5 or 7 of them were removed. We did put her on 2 months of ulipristal acetate, because that was the medicine at that time, a year back, I thought was okay. We will start it just to see whether, just to correct her anemia and let her not bleed, and come back after 2 months for a repeat procedure. So what ulipristal did, I will just show you very shortly. You can see the effect. This is the pre-ulipristal now, but you can see the amount of fibroid which is there. Now, whether to treat it laparoscopically or hysteroscopically is always a debate. Even laparoscopically, to remove such small fibroids and so many in number is going to be difficult. And she was interested in pregnancy. So this uterus, I don't think can ever become pregnant, even if you try and resect all the fibroids, which is possible. But we did our price. And now you can see the picture after ulipristal. You see the vascularity has reduced appreciably. Those sizes of the fibroids have diminished to about 30 to 40%. And that was the time when we thought we can remove more fibroids, and we removed at least another 15 to 17 in that setting. And then followed her up with just hormonal treatment just to keep her off menorrhagia. And she did respond to the medication, which she was not responding prior. So we have advised her an LNG IUD, so that we just made her, counseled her that pregnancy is not going to be a priority at all. If she is young and she didn't want to remove the uterus, because that's going to be a big stigma in her family. So what we encouraged her was to at least put in this and then start later on, see how the fibroid responds, because any fibroid you remove in her is going to multiply and come back very soon faster. So this is the fibroid. You can see hardly any bleeding after the action of ulipristal. See how beautifully it cuts, and it's become much more softer than what otherwise would have been. So this made us job a little easier, because we could resect it with a lesser fluid absorption, because the veins and the capillaries had diminished to a great extent. And we did a job of complete removal as much as possible, which was seen inside the cavity. We tried and removed even the smaller ones, which was projecting into the subserosal rear, and we did allow her to come back after a couple of months, and she was responding better. And when it had gone to Kanpur for some other workshop, she did come and meet me, and her LNG IUD was continuing, and her menorrhagia is diminished to a great extent. And she showed me a report of hemoglobin of almost 10.5. So that made us believe that at least hysteroscopy in this case did help her. Of course, conception is not possible in this sort of a uterus. That's what I would believe. And I'm sure you also appreciate that so many fibroids to remove, It would not have been possible but for this minimally invasive approach. See, the size of the fibroid, which were much bigger in the previous, before ulipristal, had diminished to a great extent. And of course, we were trying to not to damage the adjacent endometrium as much as possible, but at the same time, remove all those fibroid which was inside the uterine cavity. So this was one of the very rare cases, which that is why I thought, let me present this as a a good, interesting case, which can be managed hysteroscopically in today's time. Now, this was another interesting case. 30-year-old unmarried girl, almost bleeding for 9 to 12 months, came to me, and I'm sure you are appreciating this particular. The uterine cavity is clear, and what sonography showed was about 3.2 centimeter fibroid mass inside the cervical canal, and none ever bothered to put in an hysteroscope. She had consulted about 3 or 4 gynecologists before me. Nobody really bothered to put in an hysteroscope or find out what it is, and she was just bleeding every day. And when we went in, this was the appearance. It was multiple polypoidal tumor in the cervical canal, right from the external os. And once you enter the uterine cavity, you will see this is empty. Uterus is absolutely empty. I'm sure you're appreciating the ostia. Uterine cavity is perfectly okay, and the whole mass is just below the internal os. On the way back, we can come up to the internal os, and then the mass can be again seen. So this was looking scary, and the look of it itself tells me that this is not a normal pathology. This could be adenocarcinoma. This is an hysteroscopic anatomy one has to recognize. So a 30-year-old unmarried, bleeding for 1 month, was in for a shock when I came out and counseled the father and the mother that I feel this looks to be malignant. So this was a very small Gubini resectoscope, which we did put without dilatation, and resected the whole tissue which was there inside the canal. We thought at least we will remove everything possible, and we did remove almost everything with that counseling that if at all something is there, we may remove, but then wait for the histopathology report. Unless the pathology report suggests what, we won't be able to suggest a future course of action. And we could remove everything in those 20 minutes, multiple small polyps, I'm sure you're appreciating. And at the end of it, this was the diagnosis. Atypical endometrial proliferation, indistinguishable from well-differentiated adenocarcinoma, and even immunohistochemistry was done. So this, we did counsel her, and she was put on a long-term progesterone therapy, and we are following her up now very closely. But as of now, the sonography is not showing any mass inside the cervix. But we have counseled her that, of course, she's unmarried. She can't go in for pregnancy sooner, though we want. But we have said that we'll just follow up, take your decision, and she has to come back. And just to complete my talk, that today, majority of heavy menstrual bleeding can be controlled by either hysteroscopy or this beautiful device. And that's the end of my presentation. Thanks for the patient hearing. Thanks for giving me time, Niranjan. Yeah, we can.
I really want to compliment and congratulate Dr. Krishna Kumar for these fantastic videos. I think they're really knowledgeable, and I'm sure a lot of people who are watching, the postgraduates especially, will learn a lot from these videos. Thank you very much.
That is why I thought, let me show only this, because I didn't want to show a regular myomectomy or endometriosis. I said, these are something most of you must have not seen. So these were just for a present. Thank you.
The global fibromatosis I've never seen.
Yeah, even I've never seen this.
The cases were interesting cases, and the message must be just because of hysteroscopy is there, we can do the lot of procedures with there. We need not have to open, but always it has to be correlated with the ultrasound finding and then procedure.
100%. Of course, everything ultrasound is the magic. That is the our stethoscope. Without ultrasound, you can't do a good hysteroscopic surgery. Imaging is required, and wherever possible today, laparoscopic surgery is a big debate whether we can do further on, so how long or how soon we can do, but most of the cases can be now tackled by hysteroscopy wherever we have, menorrhagia is mostly an intrauterine pathology, intraendometrial pathology, and hysteroscopy gives you answers for most of them. Thank you.
Dr. Krishna Kumar, I had one question to ask.
Yeah.
Sir, in the case where you unfortunately found the endometrial carcinoma,
Yeah.
there is often a scare of some of the surgeons that by using high pressure fluid distension, we are likely to disseminate the carcinoma. What is your take? And is this really true, or
Right.
you think it's more
No,
of
that's a very relevant question. I would definitely accept that there is always a possibility that you're going to disseminate, because hysteroscopy is all about distension. Now, most of the papers which I have read, they all said that malignant cells were found in the ascitic fluid or abdominal fluid post hysteroscopy. But to our luck and to our happiness, they say the prognosis has not deteriorated. Presence of malignant cell post hysteroscopy has not changed the staging of the patient or the long-term prognosis. So that was one. So most of the time, the hysteroscopic fluid, if the pressure goes above 70, that is when the time the tubal ostia starts opening up. So if you are able to operate at lesser pressure, your dissemination into the peritoneal cavity is supposed to be appreciably less, means you can regulate that to a great extent. And in this case, which I showed you, it was totally intracervical. So my problem of going into the uterine cavity didn't arise at all. We were much below the internal os, and the fluid going into the endometrial cavity was appreciably less. Most of the fluid was draining out because we were using though a lower pressure, but somehow we could manage and see the whole cervix because it was totally ballooned and bulged. But that question of going malignant cells going into the peritoneal cavity should always be kept in mind. Use lower pressure when you're doing hysteroscopy in a postmenopausal patient or in a suspected case of adenocarcinoma. Don't use higher pressure.
Thank you, Dr. Krishna Kumar. I'm sure the audience is loving such a fantastic content. Wow. Who could have guessed that such a content could be seen through leaders and seniors of this country? Sir, you have presented a fabulous case. And now we start with our case presentation, none other than Dr. Krishnendu Gupta. The mic is yours. Please go ahead.
Thank you very much, Dr. Ranjan, and at the outset, thank you for this opportunity. Well, Mrs. LMN, 34-year-old multiparous woman, presented to the gynecological clinic with heavy menstrual bleeding since past 4 months. And with bleeding for 8 days and passage of clots with dysmenorrhea. She has a past regular menstrual history of menstrual cycle of 28 days. She did not have any intermenstrual or postcoital bleeding. She did not also have any bowel or bladder complaints. She's otherwise fit and well without any major medical and surgical illness. A family history is also not significant. So basically, she's a 34-year-old multiparous woman with heavy menstrual bleeding for the past 4 months, bleeding for about 8 days, and passage of clots with dysmenorrhea with past regular menstrual cycles. So on examination, her general condition is fair, vital stable, systemic examination is normal. Per speculum examination, the cervix and the vagina was found healthy. Per vaginum examination, uterus is bulky, anteverted with bilateral fornix is free. The ultrasound of the pelvis was done and was suggestive of a 2 into 3 centimeter soft tissue mass within the myometrium on the anterior wall of the uterus. So what is the most probable diagnosis is what we would first have to think. What more investigations would one like to do in this case, and how would we want to manage this case?
Please go ahead, sir. You have to answer.
Yeah, so basically from the ultrasound, it's quite clear that it's a small intramural anterior wall fibroid or myoma. And I think we've seen a beautiful myomatous picture, which Dr. Krishna Kumar showed us. And what other investigations would you like to do? I mean, one of the most important things that we would like to do in such cases is, of course, the complete hemogram, because when someone bleeds so heavily for the past 4 months, for about 8 days, then of course we have to make sure that she doesn't get into severe anemia. And of course, all other routine investigations can also be done. But I think more importantly, we have to concentrate on the hemogram and of course rule out any other features if she already comes with anemia, whether she's got any other blood coagulation parameters, how they are and stuff like that. Now, if as it clearly showed that she was kind of her general condition was fair and basically no other kind of positive findings were there other than a bulky uterus and this small fibroid, I think a lot of the patients do very well with counseling and also with just local measures to take care of the bleeding. So I think oral, like we can always think of tranexamic acid here, we can think of mefenamic acid, which can kind of bring down the mean blood loss. And if not, you can obviously try this, counsel her, and if it helps, like let's say since the first 8 days she's bleeding, maybe you can start the tranexamic acid from day 2 or 3 when the flow really increases, carry on for about 5 days, 3 times a day, and then see, at least ask her to maintain a good menstrual diary and have a look at how much she's bleeding. Of course, in case it does not settle in a couple of months with your really this kind of a medication, we can definitely think of some kind of progesterogenic therapy as well to stop the bleeding. And the choice of progesterone, it needs, whenever we want to arrest any hemorrhage, we want to select some of the 19-nortestrone derivatives, like let's say norethindrone or norethistrone acetate to do that. So this would be my take, because I don't think, I mean, we need to do anything more dramatic in this kind of in this case right now, unless she again comes up with more bleeding. Then of course Dr. Krishna Kumar showed how beautifully you can put in a scope and have a look whether there's any local cause and stuff like that. Anyone else?
And the Indians have come alive. These doctors of India, they never give up, do they? I just remember this from our ace commentator Tony Gregg, who used to say this, and that's what exactly is happening. Sixer after sixers, the presentations are going crazy, and there are more than 1,000 doctors who are logged in. It's a wonderful case discussion, Dr. Krishnendu. You have hit the bullseye with a proper diagnosis, and how would you treat it with the heavy menstrual bleeding, with tranexamic acid, NSAIDs, and obviously, if required, an hormonal treatment. She doesn't require any. Wonderful, sir. Thank you so much. Any comments anyone would like to give? The forum is open. Or then we move on to the next case. Thank you. Dr. Krishna Kumar, please go ahead.
Right. This is a 27-year-old lady, married for 3 years, nulliparous, of course, presented to the gynecological treatment first for infertility, but she did have heavy menstrual bleeding since last 5 months, and of course dysmenorrhea. So this was a young girl with coming for infertility treatment, but also seems to be having some pathology. She had no other complaints of any major illness, and pelvic examination, uterus was about 6 to 8 week size with no palpable adnexal mass. So definitely we need to investigate her and find out why is she having this menorrhagia. Yeah, so ultrasound definitely showing a very beautiful mass of around 3.2 centimeter, I think, extending into the endometrial cavity, and adnexa were without any abnormality. So sonography is giving us a great lead. By the history, of course, one can conclude that she does have some endometrial pathology, and sonography confirms that this looks like to me a submucosal fibroid, so around up to 3 to 3.5 centimeter. So definitely, the diagnosis is submucosal fibroid with subfertility. Whether submucous fibroid is causing the subfertility, or definitely it has to cause the menorrhagia. But subfertility, we need to rule out other investigation apart from a routine hematological investigation, which should include a thyroid and prolactin in every patient with infertility, and male factor semen analysis has to be done. So if these things are normal, anyway, for controlling a menorrhagia, she needs immediate hysteroscopic intervention. And can I share the screen?
Yes,
My
please.
screen, yeah. So I'll just show you definitely, if all other factors are ruled out, I would definitely go ahead and put in an hysteroscope counselor that she needs hysteroscopy. Again, a favorite subject for me. When such fibroids you see, and amongst the submucosal fibroids, you will agree that amongst all the myoma complication, abnormal uterine bleeding, subfertility or infertility, recurrent pregnancy loss, bulk related symptom, submucous fibroid is implicated in all. So whether you're justified in doing a subserous fibroid, asymptomatic, or an intramural fibroid in an infertile couple is different. But submucous fibroid you find, you definitely go ahead and remove the fibroid, taking care that you don't damage the endometrium. But what I would like to show you a very interesting video here again. You know, we all learn about 0, 1, 2, 3 classification. But when you go inside, you see that it is totally different. So I rely more on the Lasmar classification. That gives more exact idea, because lateral wall fibroids are always more difficult. Not only the location, even the length where it is extending into the myometrium, right from the internal os up to the fundus. So all that gives a scoring system, which you can see in the right side here. So anything above 7 is a little difficult to manage hysteroscopically. So this was almost 8 or 9, but here again, hysteroscopic surgery is one such thing where you can do it in 2 sittings if required. So counseling of the patient is required. And here you can appreciate that as we go on cutting with the loop, more and more fibroid starts getting projected into the endometrial cavity, because the capsule is being cut and the capsule is now releasing the rest of the substance which the muscle is holding, and it comes back. And here you can appreciate the normal myometrial layer and the fibroid. So you would definitely take care that she is for infertility treatment also. So you must not damage her endometrium adjacent to that particular fibroid, and try and resect only the fibroid. So that otherwise will lead to adhesion. So here you can appreciate that you are seeing the normal endometrium, you're seeing the normal myometrium, and you can see that this is fibroid, so it needs more correction, more cutting, more resection. So hysteroscopic resection is one surgery where the most dreaded complication of fluid overload can occur. So you need to have a dedicated team who will keep on telling you about the fluid deficit, and make sure you're using bipolar current, because you can use the safe media like saline or ringolactate and not depend on that dreaded media glycine. Glycine in our operation theater is never ever kept. It has gone to museum for the last 10 years. Now, problem with hysteroscopic resection is these debris keep coming in your way. So you need to learn how to keep it away from your vision, and at the same time not take out the resectoscope. Here you can appreciate the normal myometrium. Here you can again appreciate the fibroid is still there. So more you can go and cut, and this is now go a little superficial on the fibroid and not damage too much of the myometrium. You have to resect just a little superficial as you go very close to the myometrium, and you can appreciate that most of the lateral wall fibroid has been removed. So this fibroid was almost 4 centimeters sitting on the left lateral wall, right from the fundus into the internal os, and left lateral wall is always a little difficult to remove. But now more of the fibroid is there located in the anterior wall, which was not seen initially, which was all major into the intramyometrium, which was a type 1 to 2 myoma. But in Lasmar, this gets a beautiful classification. So anything above 7, one should not do hysteroscopically, or do it laparoscopically, or do it in 2 sittings. Anything less 1 to 4 is easy to do. 4 to 7 is little difficult. Above 8 is extremely difficult hysteroscopically. And this, we are coming to the end of the myoma resection, and this patient will be given 2 months of rest period for that particular endometrium to heal, and before you can take her for fertility treatment. And her menorrhagia would definitely get cleared off in those 2 months, because you have removed such a large mass, which was the main pathology causing her. So small pieces are left behind. You can see that the rest of the myometrium is quite clean, and we are almost coming to the end of the resection. So this patient again goes home in 6 to 8 hours. So any age, you are awarded a hysterectomy. Thank you. So this patient then can be taken for fertility treatment. I would advise a 2 months gap before we start fertility treatment for her. Yeah, Ame wanted to ask some question.
Sir, as you have seen, it was quite a large and challenging fibroid, and you managed it so beautifully. What I want to ask you is that, like you said, she's a young girl, she's interested in future fertility, and therefore trauma to the endometrium has to be minimized. Normally, when we do any hysteroscopic adhesiolysis or any septoplasty, etc., we do give estrogen to the women to cause regeneration and proliferation of the endometrium. Now, when there is so much of cautery being used and dissection being carried out for, although for the fibroid removal, do you have to give estrogen in these patients, because it's a double-edged sword here?
Quite right. No, that is again a very good relevant question. I was just going through the literature regarding preventing post-operative surgical adhesions, and today Asherman's is on the rise. Previously only DNC was the culprit. Now today any hysteroscopic surgery we do can lead to intrauterine adhesion. So amongst the preventive strategies, hormonal treatment is the least effective, they say, as far as adhesion prevention is concerned. Since majority of the surgery we do is immediate post-menstrual phase and estrogen is as such available, they say giving estrogen doesn't make really sense. Now coming to this patient, yes, the cavity, the fibroid looks very large, but once you have resected, the defect will be hardly 0.5 centimeter. And the rest of the endometrium is more or less very clean and healthy. So it is expected that that particular layer is definitely covered by the rest of the endometrium. And in couple of patients whom we have done relook hysteroscopy, we have found adhesions to some extent, yes. And lateral wall adhesion, here the adhesions are not going to be that important in her case, because they are very lateral, and the almost 90% of the cavity, the fundus, the anterior wall, posterior wall is all absolutely clean. Now, when you are doing a repeat sonography after 2 months to evaluate your endometrium, if at all you think there is some problem, definitely a relook hysteroscopy is better than thing. Now, if this fibroid was in the anterior or posterior wall, placing a Foley's balloon would be one strategy which I would employ to prevent that adhesion. That just for 5 or 7 days.
For a short term,
yeah, for 5 to 7 days. Now you can't keep it for more than 5 or 7 days. That's what the literature says. Any intrauterine device. We have no experience with other ILO barrier and seprafilm, all those things. We have never got it in India. But what we routinely use is Foley's catheter whenever we want to prevent or we suspect that adhesions can occur.
We will go to Dr. Pesci for a short comment, followed by Sarita. Then we will go to
that was a good case which you had shown. I just initially want to add the point that you had told that if there is adhesion occurring afterwards, or if the patient doesn't conceive after a submucous myomectomy, definitely we have to do a repeat hysteroscopy. And then if there is severe adhesion, then I usually put a IUCD and also post-operatively give estrogen also. But I just want to add one more thing. Pre-op cases, if there is any doubt whether the myoma, how far it is there, definitely we can go do the Lesmar or step W classification, that is other name. We can be aided by using a saline sonosalpingogram to know whether how far it is intrauterine and then decide whether to go for it. That is one point I just want to add. Otherwise, it was a very good demonstration of an submucous myoma, how easily even big myoma can be removed with hysteroscopic myomectomy, sir.
Thank you.
Sarita?
Yeah, Dr. Krishna Kumar. My question is that if it's a large submucous fibroid, is there any role of giving medical treatment pre-operatively to reduce the size? Will it help?
Yeah, I did show you in my previous presentation, ulipristal did wonders in reducing the size. Definitely there is a role, but then most of the literature says that it has done usually just for tiding time to improve our anemic status. If at all you want to avoid surgery and improve our hemoglobin, then leuprolide acetate we used to give. But ulipristal, when it was available and didn't have that bad reputation, we started giving for a couple of cases, but it's not a routine. Of course, more than 5 centimeter, we don't normally go ahead and do it laparoscopically, unless the patient is for 2 sitting. Now, only advantage of hysteroscopic surgery is, it's a major advantage. You can do anything in second sitting. I mean, you can just leave it at that halfway, whatever you have done, and do it after 2 weeks. Nothing happens, unlike in other surgeries. Hysteroscopic surgery can always be done in 2 sittings, so that counseling only is required. So very large fibroid, we generally go ahead and do it. If required, do it on a second sitting rather than giving all those drugs.
Dr. Krishna Kumar, I would
Yes,
like to share you with Tony Gregg's comment. They will probably need Gillette to work on one of those Gillette G2 double-edged swell heads to get through those valleys they have got there. This is what you have done. Your presentation has created goosebumps, and I feel I'm watching a World Cup with beautiful presentations by you. And we are waiting now for Dr. Fessy Lewis to start his case presentation.
Thank you all.
Okay, thank you, Niranjan, once again, and thank you, Maharashtra IAG and MOX for giving the opportunity. So my case, without wasting time, I'll go as we are running short of time. And my case is Mrs. ABC, 38-year-old woman, para-1 living one, presented with a painless lump in the abdomen, which she noticed 3 years. She has gradual distension of the abdomen since 3 years. There is history of irregular and heavy menstrual bleeding since 8 to 9 months. She also has occasional constipation since a few months. In the past few weeks, she has noticed abdominal discomfort and shortness of breath. Ultrasound, abdomen and pelvis showed large, soft mass arising from the uterus. Can you go to the next slide, please? Arising from the uterus with partial cystic areas. Even though this image is not clear, because ultrasound always with a single image, we cannot be very clear. Actually, it is a moving image will be much more clearer. So the other in the scan report tells that other ovaries were normal. So that is the thing which we have to clearly see in the transvaginal ultrasound, whether when the mass is there, where it is originating, we have to see. So the diagnosis, next slide. What is the diagnosis? First diagnosis here will be fibroid, since it is mass arising from the uterus, and whether we need another investigations to substantiate that. Definitely, as you all know, we have to rule out the where the hemoglobin status of the patient, and to manage this, since she has got only one child, and he deserves to have one more child, and this mass is big. There is we have to, since she is symptomatic, definitely we have to go for a surgical management. Can you have the next slide? Okay, so we here before starting the video, I tell that the role of MRI is limited if it is a big mass, when you are doubtful where it is extending. Otherwise, and when there is some degeneration which are confusing only, we have to go for. Let us start the video. No, the video, please.
Please start after the 45 seconds later. Yeah,
Okay. So definitely this patient, since she wanted to complete the family video hysteroscopy also, in this case, then there it was done. And we have to inject the vasopressin. Vasopressin 1 ampule is diluted up to 50 ml of saline. Usually I go for 30 ml, because only thing before that we have to tell the anesthetist we are going to inject that. Always wait, aspirate and see whether you are going intravascular, and we can put an incision as you've seen. I routinely don't go for a harmonic. We can use a simple monopolar also. And with any bipolar or this thing, after putting the myoma screening and giving traction, apply the coagulate the base. And when there is the base has to be properly coagulated to decrease the bleeding. And after that, we can go for a suturing. Suturing, we can now there is barbed suture is there, which is very easy to do. No need for much experience, but a little bit of a laparoscopic experience has to be there. Otherwise, we can go for a simple sutures using Vicryl 10. And since she wanted to have one more child, we have to go for absolute hemostasis as far as possible, because the chance of adhesion, especially in the posterior myoma, because the POD adhesion chance has to be minimized. And regarding the retrieval of the myoma, nowadays there is, as you all know, there is a controversy whether to use Morse letter or not. Definitely, it is advisable to use Morse letter in doubtful cases and a big myoma. But small myomas like this, not so big. I also don't use endobag. And Morse letter definitely must be there, but endobag is the thing what I wanted to tell. It is always safe to use endobag in this. In Morse letter, if you don't have an electrical Morse letter, small myomas like this, not bigger than 5 centimeters, we can go for a mechanical Morse letter also, which is cheaper. But of course, if you have an electrical Morse letter, it is very easy. And you can see interseed can be used if the patient can afford to that, which can reduce the adhesion. Only thing we have to go for an absolute hemostasis for that. And definitely in this era of laparoscopy, if you don't do a morcellation and if you go for a mini lap incision, it is not advisable. Definitely, morcellator facility is there. At least mechanical morcellator can be occurred, which is not very costly. Okay, so that is it. Okay, Krishnendra Gupta sir.
Messi, your presentation was right up in the black hole. I am watching a World Cup and it's amazing presentation which you have done. Dr. Krishnendu.
Yeah, I just wanted to go back to that. You very correctly said that when you have an ultrasound, a moving image is much better than a single image. If you go back to that slide where it shows the picture, if you really don't mark M and U and stuff like that, the contents of that myoma really has the basal stippling, which we can actually even misinterpret as an endometrioma.
Yes, that's why I told.
And it's a very important point because some postgraduates may be watching, this program, and so you have to think of if it's really a myoma, then you have to think of degeneration when you get such a picture, because this is something which could be a differential diagnosis when a postgraduate in the exam is suddenly given an extra, an ultrasound plate.
So definitely ultrasound, preferably done by a gynecologist or somebody from your team, is very important, and that correlates. And if you start doing it, that is a biggest advantage for the gynecologist if you have to start doing TVS for all your pre-op patients.
Lovely video as well, Niranjan.
Thank you. Now we go to Dr. Sarita and she will present her case. Please go ahead.
Yeah. Thank you, Niranjan. And can I have the slides, please? Yes. So this is a 24-year-old unmarried woman who comes with a history of severe pelvic pain since the past 6 months. On pelvic ultrasound, she has a right adnexal mass of 4 by 3 centimeters arising from the left ovary. It had a well-defined smooth border and a wall thickness of 4 millimeters. And the center of the mass showed a ground glass appearance. So I think that here with a ground glass appearance, it's a very typical appearance of endometriosis and an endometrioma. And here we are dealing with an unmarried woman. Her primary complaint is severe pelvic pain, and we have to sit down and discuss the options with her. So can I have the next slide, please? So what is your diagnosis? So I think that the diagnosis of an endometrioma is very clearly and made on an ultrasound. And the role of doing further investigations is only if the diagnosis is in doubt. It's not necessary or mandatory to do an MRI for each and every case. If your diagnosis is very clear, then you don't need to do it. Also, a lot of people tend to do tumor markers and CA-125. Here again, I think in a young girl with the diagnosis quite clear, an ultrasound is good enough and adequate, and we don't need to do these investigations. Now, when we think of her primary complaint, which is abdominal pain, we have in front of us basically the options of giving her medical management versus surgical management. If we do surgical management, remember that there is a risk that the ovarian reserve will go down. So here the patient also requests to avoid surgery as far as possible. So I think in her case, the best course of action would be to do medical management, and we have hormonal therapy available. The most effective hormonal therapy is to give progesterone and Dynogest 2 milligrams continuously which would put her in amenorrhea and would slowly reduce the cyst. Now, the other options are to give the birth control pill, oral contraceptive pills. That is also an option. And for young girls who, they are very well tolerated, they're not in a high risk group for oral contraceptives, that is another option. The advantage would be that she would get cycles, which would probably be psychologically better for her. But today, I think Dynogest 2 milligrams is perhaps the best treatment for these patients. How often would you want to monitor the progress? I think at least 3 months time we have to give for the cyst to reduce somewhat in size. And if medical management fails, well, then I think we are left with only the option of doing a laparoscopic cystectomy. And I would urge everybody to do an AMH level before doing a laparoscopic surgery. And ideally, we should do the laparoscopic surgery when the patient is keen to conceive, so that she can be advised to conceive and, as part of the treatment. Also, if surgery is done, we need to be aware that these cysts recur, and she should be advised to be on follow-up and also continue hormonal treatment to prevent recurrence till she is ready to conceive.
Sorry, it was one more sixer from you. Sixer after sixer. I'm just watching the World Cup and the way you have presented, it's amazing. There's one question. What will be the dose of Dynogest? After
So the dose of Dynogest is 2 milligrams, 1 daily, to be given continuously. And it should be started in the early follicular phase, that is from day 1 to day 5 of the cycle is the best time to start it. And it should be given for 3 months without a break. It'll put the patient in amenorrhea and relieve her, dysmenorrhea.
Krishnendu, Krishna Kumar, then
in addition, just a kind of a comment.
Yes.
Since again, postgraduates are watching. For pain in endometriosis, another new GnRH antagonist, a non-peptide called elagolix, is being studied extensively in doses of 150 milligrams daily or 200 milligrams twice daily. Some studies are going on, and in 2019 and 2020, a lot of interest has been shown regarding this medication called as elagolix to reduce pain in endometriosis, especially.
Oh my God! I want to share with you. There are 1,400 viewers who have joined now. This is amazing. And there are more and more questions been coming. And we are just waiting for the last presenter to come, which is none other than Dr. Amay Purandare. But before that, we will go to Dr. Krishna Kumar.
Yeah, now just a question to Sarita about how do you manage a patient who keep on complaining of spotting? Like, how many of your patients on Dynogest do have that intermenstrual or that irregular spotting that bothers them? So how do you tackle them, and how do you counsel them?
Yes, so I think, so that is a problem. And I have had patients who from Dynogest have had to be switched to an oral contraceptive pill because of the irregular bleeding, which is why I said both the options are there. In a patient who's high risk for estrogen, a patient above the age of 40, Dynogest would be the best option. But in a young girl like this, for better cycle control, the oral contraceptive pill is also a very good option. We can give tranexamic acid to stop the spotting. We can counsel the patient. Many of them do go in amenorrhea, but, after some time. But if that doesn't happen, then we may have to resort to other options.
Okay, thank you.
One last question, madam. Since I am more into reproductive medicine, I don't much use the Dynogest. How long can you give the Dynogest to a patient maximum?
So this is a very difficult question to answer, because people have given Dynogest for even 1.5 years, 2 years. Now, the trick in endometriosis, first thing is that we have to accept that it is a long-term problem. It's not a problem of 6 months or 1 year, but it is a long-term problem. But we have to tailor the treatment to what the patient wants. So I would think in this patient, we'd give the Dynogest, put her in amenorrhea, keep watching the cyst. And once the cyst has reduced, maybe put her on a birth control pill while she doesn't want to conceive. Take out the birth control pill when she's ready to conceive, take her off it, and then again continue her maybe for some time on a birth control pill. But yes, there are studies which show that you can give it long term. There are studies which say you can give even the birth control pill, low dose pills, right up to the age of 50.
Sarita, it was amazing scientific discussion which you have done. And I think the whole audience is just amazed by your presentation, the way you have given the reasons for that. And Dr. Krishna Kumar, thank you so much for adding that comment, and Dr. Krishnendu Gupta. So I think we'll go to Dr. Amay Purandare with his case presentation.
Thank you, Dr. Niranjan, for giving me the last case. I asked him why he's giving me the last case, and he said that, Amay, you are like MS Dhoni. You are the best finisher, and that is why I'm giving you the most challenging case. So thank you, Dr. Niranjan, for having faith in my ability to tackle this challenging case. Mrs. XYZ, a 30-year-old, married since 4 years, nulliparous and anxious to conceive. She has had severe pelvic pain and heavy menstrual bleeding since a few years. And she was told that, rather she came up with a history saying that she had an ovarian endometrioma about 2 years back, which was medically treated by her family physicians. Her evaluation at present showed that she's had a recurrence of ovarian endometrioma. The size is about 6 by 7 by 5 centimeters on TVS. And her AMH level, like Dr. Sarita said, should be done in every case of endometriosis, especially when fertility is a concern, is pretty low. It is 0.6 nanograms per ml. Can we have the next slide, please? So the question is, the questions that come to us when we are clinically managing her is that, what is the diagnosis? The diagnosis is pretty certain. It looks like from her history that it is a case of recurrent endometriosis. Recurrent endometriosis is one of the most challenging subvariants of endometriosis to tackle because there are a lot of dilemmas. The patient is also frustrated that the disease has come back again. And what would be the preferred management in this case? See, there are two issues here. One, to tackle the endometriosis, the recurrence, and the second is to preserve the fertility. Because she wants to become pregnant at the earliest. So to tackle the endometriosis, obviously there is an endometrioma. It's pretty large in size, and we would like to tackle it surgically. And could we have the video for the endometrioma, please? Dr. Niranjan, could we have the video, please?
Dr. Krishna Kumar, can you share the screen?
Yes, yes.
Actually, I have a video, but it is 7 minutes, so it will be very lengthy.
Yeah, can you see?
Yes, please. Double click.
Yeah, it is. Can you see the video?
Yes. Series 4.
Pardon?
It is not
Series 4, I think.
No, video is playing here. 1 minute.
No, not playing.
Last time.
So by the time when the technical gets started, I will ask.
I'll just finish with a few points that I wanted to say. So when you are doing this endometrioma surgery,
you can start and continue. Dr. Amay will give the commentary like Tony Gray.
No, there is only one commentator, and that is Dr. Niranjan Chavan. Nobody can beat his commentary. We are all the expert commentators. We are just here to give input.
Please, Amay, go ahead. In the meantime, we'll have the screen.
Yeah, so like I told you that the principle of endometrioma surgery would be 3 steps. First is identification. Second is drainage of the endometrioma. And the third is the peeling of the cyst wall. One must be meticulous in all these 3 steps. You want to minimize spillage.
Is it playing there?
No. The cyst wall, and last but not the least, you must ensure that you don't overdo things because fertility is a concern. Overuse of electrocoagulation, overuse of overcauterization of the ovarian substance can further compromise your ovarian function. One more point that I also want to make is that if you do see endometriotic spots around, you must fulgurate them at the sitting so as to complete your surgery. Now, before I say anything further, I would like to ask Fesi that, Fesi, a lot of papers are now coming up regarding the role of, in recurrent endometriosis, where fertility is an option, the role of primarily going in for ART, preserving or aspirating the follicles, and then going in with endoscopic surgery. So what's your take in this? Have you changed?
The same thing I wanted to tell you, and I raised the hand here. So in this particular case, since she is nulliparous and IMH is less, but she's symptomatic also. But definitely we have to go for aspirate the follicle, freeze that, then go for the, even if you get less follicles, we can go aspirate for 2 times, then freeze that, and then go for a definitive surgery, and then give for prolonged suppression and go for an embryo transfer. So that will relieve her symptoms and help her the fertility potential. But definitely we must counsel, if she is insisting for surgery first, you must counsel that already her IMH is only 0.6. Even though she is young, she may end up in ovarian failure. That is very important.
Correct.
So that's a very good point, Pesi, that you made. So our change has occurred. We were initially very, our favorite was the sandwich therapy. But now the concept of sandwich therapy has moved on to combo therapy. You need to combine both assisted reproduction and endoscopy and give priority to either depending upon what her fertility potential is or her fertility need is. So this is a change of strategy, and thank you so much, Fesi, for beginning.
One more thing I want to add, people may be doing, initially people were doing vaginal aspiration and followed by IVF. But vaginal aspiration is very dangerous because that can lead to ovarian abscess formation, ovarian function will be compromised. Definitely, if there is bilateral endometrioma where you cannot get sufficient oocytes, then in those cases we can go for an laparoscopic just aspiration of the endometrioma and give prolonged suppression and go for retrieval of the oocytes. If you cannot get enough follicles can be aspirated because of bilateral endometrioma.
The last point that I want to make before I close the case is that we must remember that recurrent endometriosis could recur again, and therefore post-surgery you will have to put her on some form of medical therapy as a suppressive therapy. We all agree that endometriosis is controlled when she is on medical therapy, and when you do surgery, you could, in the earlier cases, in the mild and moderate cases, cure it. So cure and control, these are the 2 hashtags that I want to keep in mind when we are tackling endometriosis. Thank you, Dr. Niranjan.
Thank you, Dr. Amay. It was a presentation which you did.
Krishna and Gupta sir.
Let's blaze that one through the offside field. You see, that's the best. And we had challenges with the video. And Dr. Amay, you came like a nightingale out of the blue and saved us with your wonderful scientific knowledge. And Fesi Lewis, you added into that. Dr. Krishnendu, please.
Yeah, just one question for Fesi, since he's into reproductive medicine. In a 30-year-old lady with an AMH of 0.6, with this kind of a scenario, do you actually, when you do IVF, I mean, how much of their own eggs do you actually get? I mean, or you end up using, ovum donors?
Especially young females with the AMH less, definitely the chance of getting eggs and the better quality eggs is more compared to the older female with.
That's why I asked you, because there's 30 years old with a 0.6 AMH. That's why my question to you. In your clinical practice.
Yes, definitely younger patients less than 35, there is high probability we can get. That depends on the anal follicle count and the basal day 2, day 3 FSH value also. But definitely there is high chance we will get good number of oocytes in young patients, even though their IMH is less.
Dr. Amay, Dr. Krishnendu, Dr. Fesi Lewis, you all 3 are like Viv Richards. He made 40 out of 60, 40 balls and 60, which helped West Indies win the Benson and Hedges World Series 2-1. And then we still don't have the video running, but I think it's drinks time now. And let's be serious after we have some drinks.
Niranjan, as you told about Viv Richards, his birthday and my birthday are same.
Wow. Yay.
I would like to compliment Dr. Niranjan for this excellent web series that he is conducting. I hope I'm audible, Dr. Niranjan.
I'm listening,
Yeah.
Dr. Amar.
So sorry. So there has been a change in my watching style on TV nowadays. I don't watch Netflix. I don't watch CNN. I watch only the channel called as NNC. So NNC is Niranjan's initials.
Yeah.
Okay. So thank you for bringing us all these clinical scenarios and distracting us from all the corona news,
Right.
so that we remain focused as healthcare providers first.
As you rightly said, after the corona news, it is only Niranjan who is all over India with his webinar series. Fantastic, Niranjan, you are moderating absolutely well.
And
Thank
also
you,
up.
thank you, Niranjan.
Thank you, and stay safe, all of
Thank
you.
you, yeah.
science in
We
the
should have question answer sessions, by the way. Please don't
Yes,
go.
we are not
Yeah,
going.
okay, we're here.
and science in
We are
the
going to be very serious now. There are many questions which have been asked, and the audience has gone to 1,500. There are only postgraduates, there are consultants. I got many names there. And Dr. Amay, you're not the last man. You're the man in shining armor. You're the one who is going to make India win. And India is going to win. So never feel that you're the last man to bat. So we started with the opening batsman Krishna Kumar, then Krishnendu, and obviously the middle order batting was too strong. And how we can forget the later tail order, and that's how we win. India wins against Corona. Now we have got many questions lined up. I will just take one by one to them. I start with Sarita. This question is for you. It's basically, do you give hormones when you have 2 months amenorrhea with an endometrial growth? Do you give hormones? Dr. Vinita Gokaru.
I'm not quite sure I've understood the question. What does she mean by an endometrial growth?
That means on ultrasound, she has an endometrial growth. Maybe it could be a polyp. It could be, there is no mention of any age.
So I think we need a little clarity on this patient. We need to know what we're dealing with.
Before we start with the hormone, we would like to do a
to know what we're dealing with. If you're dealing with something like a polyp, then it may be better to clear the polyp. It may not respond to hormones. If we're dealing with something like anovulation and a proliferative endometrium, then of course hormonal therapy would work.
This is Dr. Deep from Nepal. Oh my God, we have got people from Nepal, Bhutan, Sri Lanka, and even Pakistan looking at us. I am not exaggerating. Dr. Krishnendu, it's your magic. This question is for you. What is the differential place in the therapy of tranexamic acid and ethymisilate in heavy menstrual bleeding in current gynecological practice?
What is the, sorry, I didn't hear the first part.
What is the place of therapy of tranexamic acid and ethymisilate in heavy menstrual bleeding?
Well, as I said right in the beginning, that tranexamic acid is a widely studied molecule for heavy menstrual bleeding or abnormal uterine bleeding, whatever you want to take it. So for menorrhagia, it has been studied and it is considered where there are no causes found as the first line of therapy. So I think I feel very strongly about it. I personally do not prescribe ethamsilate, so I will not be able to comment on that molecule. If anybody else has got some experience with it, yes, they were available. They are still available, and a lot of colleagues do use it. But for me, I think if you have to use an antifibrinolytic agent, you go for tranexamic acid. That's the one which has got maximum evidence-based data as a first-line therapy.
Dr. Krishna Kumar.
Yes.
This question is from the lady, Dr. Sarika Solanke, and I know her. She is a resident from KM Hospital. I just spoke to her 2 days back. She is presently quarantined in a lodge in Dadar. And it's actual fact because she just did a vaginal examination of a patient which was operated by her lecturer. And she is seeing you. This question is for you. In case of a double setup removal of a fibroid, when would you plan to do the second hysteroscopic removal?
No, it can be done. It can be done. Yeah. I would put her immediately on either a luprolide or an OC pills and do it within 15 days. I would do it within 15 days, the second look.
Okay.
Even after a week is fine, but I would do it within the first 15 days.
I just want to add one thing here. I have an interesting case done for a foreign patient 3 years back. What happened is that there was multiple fibroids. We tried to map with the ultrasound. We did myoma, submucous myoma also removed, intramural also removed. But when she came after 2 weeks, there was still one more fibroid, which was intramural jetting into the cavity. Because when we removed submucous myoma, the endometrium was disrupted, and the intramural myoma became in the submucous, and we had to go for a second sitting. So I just want to add that if there is some myoma which is not totally grade 0, we can go for a second sitting, just like when you disturb the, when we just try to remove the endometrium with the subsequent uterine contraction after a few weeks, it can become submucous.
Right. You just cut around the fibroid which is projecting, just cut the capsule or just release it, it will start coming down.
Fessy, that answer was a great shot. It's little beauty. That's gone miles over the top of the mid wicket. Awesome. You hit the bullseye. Thank you. And I go to Amay. Amay, we have a question for you. What is the cutoff size for medical management for endometriotic cyst? There is no age here written. No parity.
Okay. See, you cannot have just a cutoff value for endometriotic cyst. You have to take the clinical symptoms, the priority of what symptom that you are treating her endometrioma for. But on an average, less than 4 centimeters cysts are usually responsive to medical management. If it's more than 4 centimeters, the response is much lesser.
And also, Ameya, I think age is very important.
Yeah.
Yes, Dr. Krishna Kumar, you wanted to add something in this comment?
No. I agree totally that the size is important. Anything less than 4, we don't. Yeah.
Sarita, we come to you now. Thank you, Amay, for your answer. You justified the question. Any role of cabergoline for this unmarried girl? Madam Sarita, this is from Dr. Nitya.
Hello, yeah. Can you tell me again the question? I didn't get it.
Any role of cabergoline for this unmarried girl? Madam, I think it was related to a question. For an unmarried girl, can we give cabergoline?
Yes, so cabergoline has been tried for endometriosis, and there are some reports now on use of cabergoline, but I think we still don't have very clear guidelines, and I think that using Gynogest and the birth control pills are first-line treatment, but there are a lot of other second-line treatments coming in, even aromatase inhibitors and cabergoline, which we hope in the future will be in the guidelines.
Thank you, Sarita. You have answered very well. And then we go to the next question now. This is from Dr. Annapurna. Dr. Fessy, the reason for and distension and difficulty of breathing, I think it is related to the surgery which you planned for a laparoscopic myomectomy, or is it, I think related to hysteroscopy. The reason for and distension and difficulty of breathing.
And that particular case, that was just the complaint she had. And in those cases, we have to really rule out whether it is any ovarian mass. So scan is important. We have to make sure it is a uterine mass. So maybe the history of the case which I presented, there was a point of breathing difficulty.
Is the surgery seen?
Yes,
Doctor,
it is seen.
Please go ahead.
Okay.
It is seen.
They want to talk on this particular, just see the ovarian cyst which didn't play that time.
Yeah, so here we can see the first step that I said was you drain the cyst contents. So the first step would be incision of the endometrioma. The second step would be drainage of the cyst.
Yeah. Now you can appreciate your drainage without incision, contained drainage. Yeah.
It should be with minimal spillage.
Spillage, yeah.
And the third thing would be, then once you've completed the drainage, you can see the chocolate material being aspirated even before it spills into the pelvis. And the cyst collapsing totally. So that means the suction has effectively aspirated the entire contents. And now the third step is the peeling of the cyst wall and achievement of the hemostasis. And this is where you need to be very careful and not overdo things. I'm sure Dr. Krishna Kumar will agree with me on this.
Yeah, perfect. The main culprit or main blame is that you are removing too much of the cyst wall and reducing the ovarian reserve. But yes, you have to see that you remove the thinnest part of the cyst wall and try to enucleate it and try to pull it from contralateral side. Put it in an endo bag and don't try to extract it through the port or the port site. You know, you will get scar or the port site endometriosis. Always put them in endo bags and then see. And then now you can see that there were adhesions and they were all cleared off. Thank you. Sorry for that little technical hitch which I didn't.
Thank you, Dr. Krishna Kumar. The nation wants to hear Dr. Amay, and they are enjoying all this discussion, the steps of endometriosis, cyst, excision, peeling, before that cauterization, achieving hemostasis, and it is a wonderful presentation. Superb clarity of the video. I think I have never seen such a wonderful video, Dr. Krishna Kumar. I think Dr. Sarita has been called for an emergency. We will have to leave her, but there are callers from Mumbai, and I find Dr. Samar Gupta's question, and this is directed to Dr. Krishna Kumar. It is regarding risk of sarcoma versus cystic degeneration in such a mass, since USG suggested cystic areas. Dr. Krishna Kumar, can you answer this question?
No, my case you're particularly telling, or the one which I presented?
Yeah, you presented the case. It is risk of sarcoma versus cystic degeneration. He has not mentioned properly exactly. But
no, fibroid, yeah, sarcoma and cystic degeneration, you have to rule out by one, of course, an imaging. Color Doppler you would do. If there is increased vascularity, it goes more in favor of sarcoma rather than cystic degeneration. And if in doubt, of course, do an LDH. And age of the patient is equally important. Younger the patient, chances of cystic degeneration is more. Older the patient, beyond 40 or 45, sarcoma would be kept in mind. But apart from age, I think imaging, color Doppler and an LDH, these two will try to help you to differentiate between the two.
Sir, there is another question from Kavita Gadekar. Sir, how was the bleeding controlled from the resected base of cervical adenocarcinoma?
No, luckily there was no bleeding. Absolutely no bleeding. We didn't have to do any coagulation of the surface. Of course, when you're using the cautery, it is bipolar cautery, but some amount of coagulation must be happening with the cautery. But luckily, we didn't have any bleeding, and we were prepared to use a Foley's catheter. If at all, it was either you just needed to pack the cervix with either a packed gauze piece or a mop or even a Foley's balloon catheter, and instill about 30 ml of fluid just temporarily.
Dr. Nageshwari Nanda, she is speaking from South India. In the event of COVID-19 of spread around, hysteroscopy is advocated. Obviously, it is advocated, and FESI is laparoscopic surgery being avoided, or is it allowed? FESI.
Laparoscopic?
Laparoscopic surgery to be done in COVID-19 lockdown period.
Only in emergency, and otherwise it is not advised, because it is told that fumes generated may be not good. So, but only emergency cases only. Especially, we have to track the history of the patient, whether patient has got any contact to the affected people. Krishnamar sir want to tell something?
No, any surgery under regional anesthesia, epidural spinal is much more safer when you're talking about corona transmission. General anesthesia, because of the oropharyngeal route transmission, the anesthetist stands a very high risk of getting infected. So anything done by epidural or spinal, you can safely go ahead and do as per the current guidelines is. Of course, you have to take all other PP precautions, that apart. But definitely laparoscopy requires GA, so that is one main content. And then the risk of fume spreading, whether there are virus in those particles, we really don't know. Still we have to wait and wait for the studies to really come out with clear ideas.
Wonderful sixer after sixers are going and India is winning the match. I'm very happy. Though it's an evening, night time, there are many people who are logged in and it's a really amazing presentation and discussion which are going on. There are some 10-15 questions still lined up. I'm trying to come up to the space. I'm trying my best. Dr. Amay, this is for you. Dr. Delina, up to what size of endometrioma can be managed medically in an adolescent girl? You have already answered it, but Dr. Delina wants to, has probably joined later on.
Yeah, so I already said that it's not just the size that matters. You need to see the entire clinical picture before you address an endometrioma. Of course, in those where you are using medical therapy, the best response is seen when the size is less than 4 centimeters.
I want to share, Delina is from Sri Lanka. And it's amazing. There are many questions which are coming. This is for Dr. Krishnendu. Well, I can take this for you, but the audience has gone in a dramatic style. The whole of Bengal are on their feet. India's historic win over Australia in Kolkata 2001. Krishnendu, are you there?
It seems to have gone.
Just now, I think
I think he has just left, but I think he will join us, no issue. We have got many questions. This is for Dr. Fessy, ma'am.
Yes.
Sorry, ma'am, I think this is for Sarita. Ma'am, can you please repeat the dose of Dynogest? And also COC from which day to which day? Fessy, can you take this for Sarita?
I don't use much of Dynogest, so experts can tell.
It is 2 milligram per day.
So
It can be taken for about 6 to 9 months, but you have to monitor the patient. And also, I think clomiphene citrate, that's what she means. It can be started from day 2. That's fine. Dr. Amay, we come back to you. This is the question from Sangeeta Srivastava. A girl of 13 years, Minar, 5 months ago, has regular menses for 2 cycles, amenorrheic for 3 months. Now she's bleeding since 10 days. How do we manage? Her weight is 40 kg. She's a 13-year-old girl with heavy menstrual bleeding.
So there are two main things that we need to look at. One, is this just an immaturity of the HPO axis, which is known to occur at the time of menarche and settles down usually in 6 months? There will be irregularity in the first year. 1 in 3 girls do experience normal menses. 2 in 3 girls will have some irregularity. But what is more important is that, is this heavy menstrual bleeding not because of a physiological cause or because of a pathological cause? And the pathological cause that you are most worried about in this age group is coagulation disorders. And therefore, you need to evaluate coagulation disorders, take an hematologist's opinion in this, and then if a coagulation disorder is present, then treat it with the necessary medications. At the same time, also ensure that her hemoglobin is optimally increased by giving her the iron, B complex, folic acid supplements, so that her day-to-day productivity is not affected. So there are 2 things. 1, counsel regarding physiological, and 2, look at pathological. And in pathological, the most important in that age group is coagulation disorders.
Dr. Krishnendu, thank you,
Yeah,
Dr.
I was totally logged out suddenly. I don't know. There was no connection. I just couldn't even.
Yeah, Krishnendu, welcome. Thank you so much.
No, I was trying my best to log back.
You're the Bengal tiger. Thank you so much for joining.
No.
And this question is for you. Prior to hysteroscopy, do we wait for bleeding to stop and then do hysteroscopy, or go straight for it?
I don't think we should ever attempt hysteroscopy when there's active bleeding, because you won't be able to see anything and you're going to actually cause more harm than good. That's what I feel, sir. I mean, you should make every attempt to stop the bleeding, and we have adequate, I think, measures to stop the bleeding before we attempt hysteroscopy. There's nothing called as emergency hysteroscopy. I've never heard of that yet.
Krishnendu, I want to say something. There is Dr. Basanti Mukherjee. We want to hear Dr. Krishnendu. We are for him. It's like there is a lot of fan following going on and they're cheering you. You're batting
Thank
sixer
you.
after sixer. Thank you so much.
I was
It's
almost
amazing.
0 and out till I could
No,
get
no,
back
no.
again.
I don't think so. Well, Dr. Krishna Kumar, prior, this question is for you. I think there are repeated questions, but I'm trying to filter as much as possible. Dr. Sudhamani is writing this question. A lady of 32 years, having married, having 4 fibroids, 5 centimeter and 3 more fibroids. Basically, the uterine size is 16 weeks. And how to go about this?
No,
Dr.
her
Krishna
presenting
Kumar, Dr.
complaint,
Messi.
her presenting complaint is what? Menorrhagia, I mean, right?
Yeah,
So
she's 32
such-
years old.
Right. Now, in
4
this
fibroids,
case,
5 centimeters
32,
and
yeah,
1.
the fibroid size are huge. Definitely she requires surgery. Now, again, only for the age, you have to offer her whether she wants to not avoid, rather avoid hysterectomy. Then you have to go for myomectomy, remove the fibroids, and then put in some form of an LNG IUD, and then wait. If she is ready for a hysterectomy, go ahead and do. If your kids are quite old, beyond 12 to 15, I would go ahead and do an advise her an hysterectomy. If not, then a myomectomy with an LNG IUD.
Conceive. I'm sorry, but she wants to conceive.
So you said
She
4
wants
kids,
Dr. Krishna Kumar.
4
She wants
children.
Dr. Krishna Kumar to see that you make her conceive.
Right. If she wants to conceive, then definitely do myomectomy, laparoscopic, because they are 5 centimeter, quite large. And I would go ahead and, of course, perform an hysteroscopy, rule out any submucous element, any smaller fibroids, because many a time you miss smaller fibroids. To always prior perform this hysteroscopy, rule out any intracavitary pathology, and then do a laparoscopic myomectomy. Wait for 3 to 6 months, and then allow her to get pregnant.
So here I like to add here the importance of mapping of myoma is important.
Of course. All those care of laparoscopic myomectomy, I didn't want to elaborate. I just wanted to tell the main treatment here. Definitely, you have to map to really locate and remove all the fibroids, and you're prepared well before the surgery.
I just want to ask sir one question. Have you ever, because of multiple myomas, confused whether you have removed myoma and brought the ultrasound machine into the theater and checked whether your myoma is left or not? Because you have done
Once sometime you don't get all the bulges outside. When sonography, you have read that you have seen 4 fibroids of 3 centimeters, some are big. So once only in my whole history of 20 years, I had to really see whether locate that fibroid, because sometimes the bulges look like fibroid and they're not fibroid. And once I had to do, only once, otherwise not as a routine. As you said, we have started mapping properly. So once you go prepared with that mapped in front of you, you don't get bouncers or you don't get stumped during the surgery.
Bouncer is coming for Niranjan.
Doctor, there are many questions. There are many people from all over India. This is Dr. Ashwini Kalyankar from Meera Road. This question I would like to ask Dr. Fessy. It is regarding a fate of accidentally finding an adenomyoma instead of a myoma while doing laparoscopic myomectomy, and she is an infertile patient. How will you manage this case?
Okay, definitely that once in a while it will come. However we do, when we put the incision, it may be adenomyoma instead of myoma. In those cases, we have to, since if she's an infertile patient, you have to go for try to excise maximum as far as possible, go for a wedge-like incision. But we must be careful that unlike the myoma bed, it will be difficult to get an approximation. So we must be careful in that aspect also. Otherwise, the healing of the myoma bed will be very much problematic for the subsequent pregnancy. So with that in mind, try to do the maximum adenomectomy, go for a wedge-like incision and have a proper approximation as far as possible. And luckily in adenomyoma, the bleeding from the base will be very less. So that aspect will be less, but we have to be careful about the approximation in that patient. Definitely we have to go for a complete adenomyoma as far as possible, even if it is adenomyoma during the laparoscopy.
Oh, wonderful answer. Fessy, one more ball to you. You have to hit this 6 because you are the reproductive head of the famous Amrita Institute. can we go for gonadotropin stimulation and IUI in endometrioma case, or we should go for IVF? Your take on this?
That depends on the age of the patient, the ovarian reserve, all those things. And if you are planning the IMH is less, definitely better will be to go for an IVF. And as discussed, we can go for, we can avoid even laparoscopy, or if the patient is symptomatic, just like the case we discussed, we can go for a surgery after freezing the embryos. But otherwise, the ovarian reserve is good if it is a young patient, and definitely we can go for a laparoscopic cystectomy and then go for ovulation induction in that patient. And as Amir told, we can go for we must go for a cauterization of all the lesions, even if you are going for an endometrioma, so that the readhesion formation and subsequent pregnancy is better in that patient.
Thank you, Dr. Pesci. There are still many questions. I'm just getting questions. This is the last question. I will take probably second last. Dr. Amay, you're still not out and you're still on the pitch, and it's a day-night match. And we are just going to win this match only because of you. This question is for you. What can be the medical management for adenomyosis in a multiparous woman? She might be approximately 30 years old.
Okay, so as we know and we have been conventionally taught that the only cure for adenomyosis is hysterectomy. I hope you can hear me now.
Yes. Yes.
Okay. Yeah, so we've always been taught that the complete cure for adenomyosis is hysterectomy. But there are now certain medical managements or non-surgical managements available depending upon what the adenomyosis symptoms are. So if it is heavy menstrual bleeding, of course, Mirena or the other hormonal preparations do have some effect. If there is excessive bleeding in every cycle, you could reduce it by using primarily a course of antifibrinolytics. Also, there could be a role of using certain other preparations like the contraceptive pills or DMPA for long-term usage. But with the advent of the LNG IUCD, as well as with the advent of agents like GnRH analogs, we are much better armed in managing these patients medically and avoiding surgery. But surgery, I must confess that surgery is the ultimate cure.
Thank you, Dr. Amay. Now, last comment.
But I think it's very important that LNG must be tried, because especially if there's pain with adenomyosis, it works very well.
And what I say this thing is that if you put LNG IUCD, there is high chance for expulsion also. In those cases, first 2-3 months, if you supplement with any GnRH agonist, will be better in those patients.
Okay, orally, yeah.
Dr.
Orally progestogens or GnRH analog.
Yeah.
About heavy menstrual bleeding, and then we close. Each one of them have answered. Your last comment on heavy menstrual bleeding.
Yeah, my last comment on heavy menstrual bleeding is, of course, diagnosed properly by good imaging, and 80% of heavy menstrual bleeding can be corrected by hysteroscopy if required, if at all a minor surgery, apart from medications.
I think counseling is very important.
Very good.
And you have to spend a lot of time on counseling, giving them the pros and the cons, what's available, what can be done, what cannot be done, because a lot of people have got these great expectations after reading everything through Google and internet, because they feel whatever has been done in the US yesterday is available in our country today. So all these things have to be explained to them, what is practical, what is feasible, and what can be done. And the choice is available.
I think always, especially in the adolescent group and the perimenopausal group, we must definitely rule out any organic lesion, any lesion. Otherwise, we must counsel about it can be because of the dysovulation. So that portion, especially as are told, we must counsel properly and not just do surgeries for that, because heavy menstrual bleeding can be relieved. Suppose if the patient is having associated backache or something, that won't be get relieved if it is associated with in the perimenopausal age. So counseling is most important, and properly discussing with the patient is very important.
Okay. So, Dr. Niranjan, last ball, 6 runs for India to win. We are at Wankhede Stadium, and like MS Dhoni, I am on strike. It's a day and night match. So, as far as heavy menstrual bleeding is concerned, I'm ready to hit the sixer. So, many causes, many investigations, many treatments. Okay, but we need to rationally and scientifically approach each patient depending upon whether it is acute or chronic. So, what is the severity of the bleeding? Stop the bleeding, ensure that if there is acyclical bleeding, to ensure cyclicity, and if there is a pathology, to appropriately treat the pathology either medically or surgically. Most importantly, keep the age group of the patient in mind, because certain pathologies will occur at a higher incidence in a particular age group as compared to the other age group. But more importantly, treat every heavy menstrual bleeding, because if the bleeding is heavy, it can cause a disruption in the quality of life of the woman. Respect her sensitivities. Thank you so much. I hope I've hit the 6 in Dhoni style.
You have hit the 6,
Absolutely.
but there is still 1 run to win. And that 1 run is going to be taken by none other than Dr. Krishnendu Gupta.
No. This is no. Ameya has already won the match for us. But just a closing comment is just like, I mean, Niranjan, you also know that FOGSI, we have a wonderful GCPR on AUB. A lot of effort was spent in 2016-17 for this GCPR, and it's available in the website. I think all of you should actually, kind of enhance whatever we have. All of us have learned something or the other today. Dr. Krishna Kumar's wonderful videos. I mean, all of us have picked up something or the other from each one of us. The FOGSI GCPR is something that all of you should go back and have a look and read. I mean, it's been by ICOG and FOGSI together. So it was a wonderful experience being a part of that. Thank you, Niranjan, for this wonderful opportunity, and to TOG, everyone in TOG, for this fantastic opportunity.
It was wonderful to be part of this webinar. Thank you.
Thank you. It's a
Stay safe.
Okay. And excellently organized and well managed by the TOG. So I think, Niranjan, this is a wonderful opportunity for all of us and for all the people who has been locked down to get refresh their knowledge and to gain at least something we will gain by each webinars like this.
Thank you, Niranjan.
Thank you, all of you. This was a wonderful webinar, similar to that of a World Cup match. The opening batsman, the middle order, the last man have won, and we have won this cup, and we are going to win against COVID. I would like to thank all of you to be part of this beautiful panel discussion.